Imagine you are starting a busy OPD morning. One chair has a man with central obesity and uncontrolled sugars. Next to him is an elderly lady with long-standing hypertension and CKD, and just behind them a breathless gentleman with recurrent heart failure and edema. On paper, they carry different labels: diabetes, kidney disease, heart disease. But as you listen carefully, you realize that all of them share the same underlying story: a long-standing low-grade, smoldering inflammatory fire linking their metabolism, their kidneys and their heart in one integrated disorder which we now call cardiovascular kidney metabolic or CKM syndrome. In this session, I am not going to talk to you in bullet points. I want to tell you a running story, a journey from basic immunology to bedside decisions, so that the next time such patients sit in front of you, you can see the invisible immune system working behind the scenes, and you can consciously choose therapies which also modulate that immune storm. Let us first meet the main players of this drama, the immune system. Think of innate immunity as the first responders of a city, the police patrol cars and fire brigade who rush immediately when there is any signal of danger. These include macrophages, neutrophils, dendritic cells, natural killer cells, and the complement system, all programmed to respond quickly but in a non-specific way, using pattern recognition receptors to identify broad signatures of microbes or tissue damage. In contrast, adaptive immunity is like a specialized investigation agency with highly trained officers, T cells and B cells, which take some time to get activated, but once they respond, they are extremely specific and they remember the enemy for life. CD4 helper T cells coordinate responses. CD8 cytotoxic T cells directly kill infected or damaged cells, while B cells differentiate into plasma cells and secrete antibodies, which can neutralize pathogens or mark them for destruction. For many years, we thought of this immune system only in the context of infection and classic autoimmunity, but now we know that the same cells and mediators also respond to metabolic stress, nutrient excess, and organ injury, creating what is called immunometabolism. Immunometabolism simply means that immune cells change their fuel preference and their behavior according to the metabolic environment around them. When they need to fight, they rapidly switch to glycolysis, even in the presence of oxygen, and become highly pro-inflammatory, secreting large amounts of cytokines. When the threat is over, or when they have to maintain tolerance and tissue repair, they depend more on oxidative phosphorylation and fatty acid oxidation, which favors a more regulatory, anti-inflammatory phenotype. This metabolic reprogramming is critical in CKM syndrome because adipose tissue packed with lipids, vessels full of modified lipoproteins, and kidneys bathed in uremic toxins provide a very abnormal environment to immune cells, pushing them towards chronic activation. If we zoom out further, systems biology and multiomics have shown that this is not a simple linear pathway, but a complex network in which genes, proteins, metabolites, lipids, and cells interact in densely connected modules, and perturbation at one point, say chronic hyperglycemia, sends ripples across the entire cardiorenal metabolic network. That is why the American Heart Association describes CKM as one systemic disorder rather than as 4 separate diseases listed on a prescription. Now let us walk into the adipose tissue of an obese, insulin-resistant individual and see how innate immunity misbehaves. Healthy adipose tissue is not just an inert fat store. It is a dynamic endocrine organ with well-vascularized, happy adipocytes and resident immune cells that maintain homeostasis. When caloric intake remains high for years, adipocytes enlarge, outgrow their blood supply, become hypoxic and stressed, and some of them die, releasing danger signals, free fatty acids, and cell debris into the microenvironment. These signals act like a distress call to macrophages, which rush to the site, surround dead adipocytes, and form crown-like structures, a classic histological feature of inflamed adipose tissue. At the same time, the phenotype of these macrophages shifts. Instead of predominantly anti-inflammatory tissue repair M2 macrophages, the tissue becomes dominated by pro-inflammatory M1 macrophages that secrete TNF-alpha, IL-6, IL-1 beta, and other cytokines. These mediators enter the circulation and interfere with insulin signaling in muscle. liver and adipose tissue through stress kinase activation and serine phosphorylation of IRS1, thereby driving systemic insulin resistance. The story does not stop at fat. The gut-liver axis plays a powerful supporting role. In obesity and high-fat, high-sugar diets, the intestinal microbiota shifts towards dysbiosis and the integrity of the gut barrier weakens, leading to increased translocation of lipopolysaccharide and other microbial products into the portal circulation. These molecules reach the liver, activate toll-like receptors on Kupffer cells and hepatocytes, and generate further inflammation, steatosis, and insulin resistance, gradually progressing to NAFLD and NASH. This hepatic inflammation then feeds back into systemic metabolic dysfunction by altering VLDL secretion, glucose production, and inflammatory cytokine output. At the same time, expanded visceral fat releases adipokines like leptin and resistin, which promote sympathetic activation, hypertension, and endothelial dysfunction, and reduces adiponectin, which normally has protective, anti-inflammatory, and insulin-sensitizing effects. Putting it together, we see a picture where innate immune activation in adipose tissue and liver, aided by the gut, creates a chronic, sterile, inflammatory milieu that sets the stage for CKM syndrome. As the plot thickens, adaptive immunity enters. In obese adipose tissue, CD4 T cell populations shift, pro-inflammatory Th1 and Th17 cells increase, while regulatory T cells, which normally suppress excessive immune responses and maintain tolerance, are relatively depleted. CD8 plus cytotoxic T cells also accumulate in fat depots and help recruit and activate more macrophages through interferon and other mediators. Leptin and certain lipids further push this balance towards Th1 and Th17, while TREG function becomes impaired, so the brake on inflammation is effectively removed. B cells in adipose tissue and circulation start producing more pro-inflammatory cytokines and pathogenic IgG antibodies, and some of these antibodies even recognize self-antigens, adding an autoimmune flavor to metabolic disease. Over time, this disturbed adaptive immune landscape contributes not only to insulin resistance but also to the vascular, renal, and cardiac complications that define advanced CKM syndrome. Let us follow this chronic inflammatory signal to the artery wall. Atherogenesis begins with endothelial dysfunction, often triggered by hypertension, smoking, hyperglycemia, and dyslipidemia. LDL particles, particularly when oxidized or otherwise modified, accumulate in the intima, where they are taken up by macrophages to form foam cells, creating fatty streaks. But as the process continues, adaptive immune cells, especially Th1 cells and B cells producing certain antibody subclasses, help sustain and amplify this vascular inflammation, leading to formation of complex atherosclerotic plaques. Plaque instability is influenced by the balance between pro-inflammatory cytokines such as IFN and TNF-alpha, which weaken the fibrous cap, and anti-inflammatory mediators like IL-10 and TREGs, which promote stability. In CKM syndrome, the balance is tilted towards rupture-prone plaques and therefore myocardial infarction and stroke. The same immune metabolic mediators also disturb endothelial nitric oxide production, promote thrombosis, and increase oxidative stress, giving CKM patients a particularly high cardiovascular risk burden. Now turn to the kidney. The glomerulus and tubulointerstitial compartment are not passive victims. They actively participate in the immune dialogue. In diabetes and hypertension, hyperfiltration, glomerular hypertension, and exposure to advanced glycation end products injure resident cells and attract both innate and adaptive immune cells. Macrophages and T cells infiltrate the renal tissue and release cytokines like IL-1 beta, IL-6, and TGF-beta, promoting mesangial expansion, podocyte injury, tubular atrophy, and interstitial fibrosis. As renal function declines, the kidney's normal clearance of pro-inflammatory cytokines and toxins reduces, so circulating levels of IL-6, TNF-alpha, CRP, and fibrinogen rise, and a vicious cycle develops. Inflammation worsens CKD, and CKD magnifies inflammation. Clinically, we see this in CKD patients who have disproportionately high cardiovascular risk even after controlling for traditional factors Because the chronic inflammatory state, oxidative stress, and RAS activation drive ongoing arterial and myocardial damage. Heart failure, in turn, further compromises renal perfusion and gut integrity, leading to more congestion, endotoxemia, and cytokine release. So the circle of cardio-renal metabolic injury closes. Behind these organ-level events are a few key signaling pathways, almost like the software code of CKM syndrome. One of the most central is NF-kappa B, a transcription factor that, when activated by signals such as free fatty acids, reactive oxygen species, or toll-like receptor engagement, translocates to the nucleus and switches on genes for TNF-alpha, IL-1 beta, IL-6, adhesion molecules, and many other inflammatory mediators. Another is the NLRP3 inflammasome, an intracellular sensor that detects metabolic danger signals including ceramides, crystals, and mitochondrial damage. Once activated, it triggers caspase-1, leading to maturation and release of IL-1 beta and IL-18 and sometimes to pyroptotic cell death. Elegant studies have shown that obesity is associated with increased NLRP3 expression and that weight loss by caloric restriction or exercise reduces NLRP3 activation and improves insulin sensitivity, underlining its role as a bridge between metabolic stress and innate immune activation. In parallel, the JAK-STAT pathway transduces signals from a wide range of cytokines and growth factors, shaping T-cell differentiation and inflammatory gene expression, while the balance between mTOR and AMPK integrates nutrient cues with immune cell metabolism. mTOR promotes anabolic, pro-inflammatory responses, whereas AMPK activation supports catabolism, autophagy, and more quiescent or regulatory immune states. The renin, angiotensin, aldosterone system also has a dual identity. Angiotensin II is not merely a vasoconstrictor but also a potent pro-inflammatory mediator, enhancing oxidative stress, endothelial dysfunction, and fibrosis in the heart and kidneys. As clinicians, we obviously cannot routinely measure all these molecular events. So how do we see this immune metabolic storm at the bedside? Traditional inflammatory markers like high sensitivity CRP, IL-6, TNF-alpha, and fibrinogen provide a broad sense of systemic inflammation and have been consistently associated with higher risk of cardiovascular events, CKD progression, and even mortality in CKM patients. Some risk scores now incorporate inflammatory variables alongside blood pressure, lipids, glycemia, and kidney function to stratify risk more accurately. Beyond these, research platforms use cytokine profiling, immune cell phenotyping, and multiomics, genomics, proteomics, metabolomics, and lipidomics to identify biomarker signatures that can predict who will progress from obesity or prediabetes to established CKM and who will respond best to specific interventions. For example, composite indices such as the triglyceride glucose body mass index, a surrogate of insulin resistance, have been linked with incident cardiovascular disease in CKM cohorts, confirming that simple metabolic markers can capture part of the inflammatory risk. Large CKM programs are now integrating omic profiles with clinical data to move us from a one-size-fits-all approach to a more personalized, stage-based preventive strategy. With this understanding of the immune backdrop, we can reconsider our therapeutic tools as immunomodulators rather than just sugar or pressure-lowering agents. Start with the simplest yet most powerful interventions: lifestyle. Weight loss through diet and physical activity reduces adipose tissue mass, decreases leptin and other pro-inflammatory adipokines, and lowers adipose and hepatic expression of NLRP3 and related inflammatory genes, which is accompanied by better insulin sensitivity. Regular exercise enhances AMPK activation, improves mitochondrial function, shifts immune cells towards a more regulatory phenotype, and reduces systemic markers like CRP and IL-6. Diet patterns rich in vegetables, fruits, whole grains, unsaturated fats, and low in ultra-processed food, such as Mediterranean-style diets, are associated with lower inflammation, improved endothelial function, and reduced cardiovascular events in high-risk populations. Sleep hygiene, Stress management and avoidance of smoking and air pollution also contribute indirectly by reducing sympathetic overactivity, oxidative stress, and endothelial damage, all of which feed the immune metabolic circuit. On the pharmacological side, SGLT2 inhibitors have emerged as central actors in CKM management. Originally developed to reduce glucose reabsorption in the proximal tubule and promote glycosuria, they unexpectedly showed robust benefits on heart failure outcomes, renal disease progression, and even mortality in large randomized trials. Mechanistically, they reduce intraglomerular pressure and hyperfiltration, improve tubuloglomerular feedback, lower blood pressure and body weight, and increase hematocrit through erythropoietin stimulation. There is also evidence that they modulate inflammatory pathways, including down-regulation of NF-kappa B and reduction of pro-inflammatory cytokine production, as well as improvement in cardiac energetics and reduction in myocardial fibrosis, which together may explain their powerful heart-kidney protection. GLP-1 receptor agonists, on the other hand, provide strong glycemic control, induce significant weight loss, and have demonstrated substantial reduction in major adverse cardiovascular events, particularly atherosclerotic outcomes like myocardial infarction and stroke. Experimental data suggest that GLP-1 RAs have antioxidant, anti-inflammatory, and antifibrotic properties partly via downregulation of NF-kappa B, TGF-beta, and T-cell proliferation, leading to attenuation of vascular and renal inflammation. When used in combination, SGLT2 inhibitors and GLP-1 RAs appear to offer complementary and possibly synergistic benefits across the CKM spectrum, with real-world data showing lower rates of major cardiovascular events, heart failure hospitalization, and kidney disease progression compared with either class alone. Beyond these metabolic drugs with immunologic side benefits, there are also more direct anti-inflammatory strategies. Trials using IL-1 beta blockade in high-risk post-MI patients have shown reductions in recurrent cardiovascular events, supporting the concept that targeting a specific cytokine can meaningfully alter vascular outcomes. Agents aimed at IL-6 and other cytokines, as well as colchicine, have provided additional evidence that modulating the inflammatory component of atherosclerosis can yield benefit beyond standard lipid lowering and antiplatelet therapy. In obesity and diabetes research, NLRP3 inflammasome inhibitors, JAK inhibitors, macrophage repolarizing agents, and TREG-enhancing therapies are being explored as ways to break the link between metabolic stress and chronic inflammation. Even our old friends metformin and statins have strong immunomodulatory profiles. Metformin activates AMPK and dampens inflammatory signaling, while statins reduce CRP and improve endothelial and plaque biology independent of LDL lowering. The future of CKM management will likely combine lifestyle, metabolic, hemodynamic, and targeted immune therapies in a stage-wise, personalized manner. As we come back to the OPD, look again at that first patient with obesity and uncontrolled sugars. Instead of seeing only 2DM with dyslipidemia, imagine expanded adipose depots full of M1 macrophages and Th1 cells, active NLRP3 inflammasomes and NF-kappa B, leaking cytokines into the bloodstream and silently damaging his arteries, kidneys, and myocardium. When you advise structured weight loss, encourage daily walking, start metformin, and consider an SGLT2 inhibitor plus a GLP-1 receptor agonist, you are not just reducing HbA1c or body weight, you are actively cooling down that immune fire and protecting multiple organs simultaneously. The elderly lady with CKD and hypertension is not simply a nephrology case, she is in a state where reduced GFR, uremic toxins, and RAS activation have pushed her into a high inflammatory milieu with elevated IL-6, TNF-alpha, and CRP, greatly increasing her cardiovascular vulnerability. RAS blockade, SGLT2 inhibition, salt restriction, and careful blood pressure control in her are all immunomodulatory choices as much as nephroprotective ones. And the breathless gentleman with heart failure and diabetes sitting behind them reflects the end stage of this CKM network. where chronic cardiorenal congestion, gut barrier dysfunction, and systemic cytokine excess are sustaining the disease spiral. Here too, combining optimal guideline-directed heart failure therapy with SGLT2I, GLP-1RA where appropriate, and strong lifestyle and vaccination support is a strategy to calm the immune metabolic storm rather than to chase individual numbers. So the next time you write a prescription, pause for a moment and visualize the underlying immunology. CKM syndrome is not just an unfortunate combination of obesity, diabetes, kidney disease, and cardiovascular disease. It is a tightly interwoven story of immune cells, metabolic signals, and organ crosstalk that has been unfolding silently for years before the first clinical event. By understanding the roles of innate and adaptive immunity, of key pathways like NF-kappa B and NLRP3, and of our lifestyle and pharmacologic tools as immunomodulators, we gain a new lens through which to manage these patients more holistically and more proactively. In simple words, whenever we calm inflammation, we are not just lowering sugar, pressure, or creatinine. We are changing the entire trajectory of CKM syndrome for our patients and giving them a chance at a longer, healthier life. Sources: inflammation in cardiovascular, kidney metabolic syndrome, cardiorenal metabolic syndrome. An integrated approach to cardio-kidney metabolic framework, a nephrologist's cardiovascular kidney metabolic syndrome, a state. An overview of cardiovascular kidney metabolic syndrome editorial. Role of innate and adaptive immune cells in the metabolic syndrome from omics to AI, mapping the pathogenic pathways in type 2. Multiomics-driven biomarker discovery in autoimmune diseases, multiomic study of cardiovascular kidney metabolic CKM. Role of innate and adaptive immunity in obesity associated. PMC, adipocytes, innate immunity and obesity. A mini review: Frontiers, role of adaptive and innate immunity in type 2 diabetes mellitus, role of adaptive and innate immunity in type 2 diabetes mellitus. The NLRP3 inflammasome instigates obesity induced. The NALP3 NLRP3 inflammasome instigates obesity induced. The role of NLRP3 inflammasome in type 2 diabetes mellitus and adaptive immune cells shape obesity associated type 2. The cardio-renal metabolic connection, a review of multi-omic approaches to predict therapy response in cancer, and SGLT2 inhibitors versus GLP-1 agonists to treat the heart, the kidneys, SGLT2 inhibitors and GLP-1 receptor agonists in diabetic, SGLT2 inhibitors and GLP-1 receptor agonists in cardiovascular. Cardiovascular kidney metabolic syndrome, Cleveland Clinic, cardiovascular and renal outcomes with SGLT2 inhibitors. Cardiovascular kidney metabolic syndrome, Oxford Academic.